appreciate the invitation. So I will make a plug for the Astronaut Scholarship Foundation. Have to go back to the beginning. Nope. You're advancing my slides. So this is, and we'll see if anybody knows astronaut trivia. Anybody think they know astronauts? Anybody know who this is? We're all getting so old. There's a movie coming out this Friday called First Man. And it looks pretty exciting, very well done, and it's about Neil Armstrong. Stop advancing my slides. I'm not going to be able to, is it doing it automatically? So this is a scholarship program that was established by the original Mercury, Gemini, and Apollo astronauts, specifically out of the concern for the fact that our math, science, our STEM education programs in the United States are not generating the talent that we would like, and so they created a scholarship foundation that generates $3 million a year and goes out and gives $20,000 awards to the top math, science, engineering, and technology students at the 44 top engineering programs in the country. It's a great service, and the astronauts fly in and they give the scholarships, and Stanford is part of the program, and Cal Poly, and so forth. Anyways, let's talk about medication and precision medicine and remote patient monitoring. This really is coming together beautifully now in the fact that we have new data sets that are streaming off of wearable devices in real time, and now we're able to merge that information with other data sets like genomics, and then the therapeutic benefit of the medications that someone might be taking. This is a very new application. You've been hearing a lot about genomics over the past 20 years now, about sequencing the human genome, and companies like 23andMe getting a lot of attention because you can find out your ancestry if you don't have relatives to ask where they came from. But for the most part, the genomics category has not been, it certainly hasn't lived up to its hype yet. And it's not particularly actionable in a broad clinical setting. What we're starting to see now is a place where genomics has its real kind of most robust early clinical application, and that's what's called pharmacogenomics. So when it comes to pharmacogenomics, we now have to be able to look at this data and combine it with other pieces of information, and it really all comes down to whether it's remote patient monitoring of patients from home, or it's genomic data. It's too much data for clinicians to process. So when we start talking about remote patient monitoring and asynchronous care, in other words, this data is flowing in from a lot of patients, and then we need to be able to do something about it, it's going to all be accomplished through predictive and prescriptive analytics, as you're seeing here in this article from Harvard Business Review now almost 2 years ago. The real key isn't about the technology, it's not about the gadgets, it's about the data. But big data, we've already got a lot of data that we can't process and manage. And now we're going to be talking about even more data. And so most of this data flowing by us is really never recognized. And so that's why we're looking at things after they've already happened. After all the bad stuff happens, it's kind of too late. Where we want to be is to be able to tap into that data in real time, but not have to have somebody staring at the monitor or staring at the display. That's a loser. That's a loser. Write that down. It's a loser. And the clinicians are not going to sit in front of their computer and watch 1,000 blood pressure measurements flow in every morning for remote patient monitoring. That's a loser. It's not scalable. It's labor intensive. It's part of the reason it hasn't happened up to now. Well, now we've got reimbursement, yahoo, but it still doesn't solve the problem of if you're throwing 1,000 blood pressure measurements at some doctor every morning, it's still, show me the hand. I don't want that data. So it's going to be all about predictive and prescriptive algorithms that are watching the data. This is the end game. If you're just making a widget or a gadget that's going to spew out data, it's not enough. You do not have a solution. You actually might be creating a problem. If you're just sending data, you're probably generating a problem rather than trying to sell a solution. So the key is being able to tap into this data in near real time and then have predictive and prescriptive algorithms that are tuned to that data set that can take out of 1,000 patients or 10,000 patients, here's what matters right now for you, doctor, or you, nurse case manager, or you, pharmacist. And so our friends at the FDA have actually created a vehicle. This is the new frontier. It's called software as a medical device. And this is a relatively new designation. It's a 510(k) Class 2 medical device category, but it's pure software. So your device can be sending data. Let's see if this works here. There we go. So any sorts of data, device data, lab data, pharmacogenomic data, and then run that into this black box where those algorithms live. And those algorithms are going to put all that data together, make sense of it, and then on the other side is the defined output that says, based on all this data, this is what matters. In fact, it can actually make diagnostic interpretations and even treatment recommendations. Doctor, this is what this looks like. This looks like a pneumonia. We recommend starting antibiotics, or we recommend a chest x-ray. This is the software that's going to hand remote patient monitoring to a doctor's practice on a silver platter. That's what you have to do. You have to make it really, really easy. So if they have to digest mass amounts of information and figure all this out, it's not likely to happen. Then we talk about medications, the same conundrum. Right now, we put people on medications, and we pat them on the back and say, good luck, I hope it works. We'll see you in about 6 months and find out. Well, 6 months goes by, and lo and behold, that medication didn't work. Guess we need to try something else. 50% of the drugs that we put people on don't work. 50%. We're spending over $350, $400 billion per year. And half the time, we're getting no therapeutic benefit or outcome. That's really pathetic. And in fact, this was published in the journal Nature just 2 years ago. the top 10 grossing drugs in the United States, out of those top 10, and these are all specialty pharmacy drugs, Humira being one of those top ones. You see the ads on TV at night. If you or someone you know have rheumatoid arthritis, talk to your doctor. Well, that puts them on this drug, and yet the drug's not working. So the genomics is going to tell us whether or not that drug is likely to work in the first place. So you're going to see large cohorts of patients starting to get pharmacogenomics up front, and it makes sense. Some people will respond to that drug, some people won't. Be nice to know that before we spend $200 billion that we're not going to see any result from. Now, what's cool is think about combining the genomics that says this drug's probably going to work with wearable sensors that are going to be able to track the therapeutic benefit. So it's going to confirm, okay, we think this drug's going to work. We're going to put you on that drug, but we're also going to see whether or not that drug's working. It's just like you've got high blood pressure. We want to put you on an antihypertensive, and then we're going to measure your blood pressure and hopefully see it go down. It's closing the loop, and this is pretty exciting. So you're going to see vivid examples of what's called precision medication management, where we're combining totally new data from pharmacogenomics with wearable sensors and dialing in for each individual patient, does this medication make sense for you? And are you on the right dose? And are you on the right interval? You're really going to be dialing in that medication to a very high definition level of precision. So we are building out these solution sets and combining this robust and diverse set of information around not just medication sets, but also episodes of care like perioperative anesthesia, cath lab, oncology, and even impacting the entire course of care. So you get this stuff at baseline, then we know what's the right anesthesia for you before you even come to surgery. We know a lot about you that we never knew before, so we can be smarter and safer and more efficacious. Less adverse drug reactions, less time in the recovery room, less time in the hospital. When you go home, you're going to go home on the right medications because now we know which medications are going to work for you. And this is all monitored, and remote patient monitoring is going to be key because you want all this information for when they're at home, and even preoperatively. And if you see something in that preoperative baseline, maybe you need prehab. We want to tune you up before you come into surgery. Right now, everybody just gets scheduled and they show up for their surgery. The anesthesiologist has about 5 minutes to go, "No, I think it'll be all right. Let's wheel you in and hope it goes okay." Hey, I'm a cardiac surgeon. I'm the one that's pushing the bed in. Come on, put him to sleep. Anyways, you get the idea. So, I mean, it's shocking, and now what you want is to be able to go in eyes wide open, all of us, for that patient, and it's really exciting. So I know they're about to pull the hook on me. We are doing very large multi-center coalitions, if you will, on all these different categories, developing these predictive and prescriptive algorithms, taking them through the FDA. One of them is already cleared the FDA. It's got 40,000 operations. It's used by anesthesiologists in the operating room. And after 40,000 operations, has a 50% reduction in post-op MIs, 30% reduction in post-op renal failure, and a full-day reduction in total length of stay, which, once it gets installed into every operating room in the country, translates into about $220 billion per year just for inpatient surgery. So with that, I'm going to stop, and I don't know if there's 1 minute for any burning questions.
So we're running a little bit short. Maybe we can chat you in the hallway.
Okay, sounds good.
But thank you
Thanks,
so
Milton.
much.
Good to see you.
Awesome time.